Um, anyway, let's talk about CRPS and what's going on in the world of CRPS. It's um, this a talk on CRPS and its treatment and diagnosis is a whole 3-hour talk, and I have been and I have to condense the whole thing into 30 minutes. So I decided to talk about some of the more newer things, the other speakers have talked about the more they've talked about different treatments and things like that. And I just wanted to bring up to date what else is other thoughts on CRPS. I've been treating this condition for the last got 20 years now. So this is just a disclaimer. I don't have any actual or potential conflict of interest. I may talk about off-label use of medicines. This is a disclosure. I have a special interest in treating complex pain condition in adults and children, training and fellowship at the Howard Medical School, and now I am an assistant professor at the Brown Medical School in Rhode Island. So let's talk about complex regional pain syndrome. There are officially, according to the American Medical Association, there are 3 different types of CRPS. But for all practical purposes, we just focus on the first 2, CRPS 1 and 2. CRPS NOS, which means the NOS stands for not otherwise specified. These are patients who kind of meet the CRPS criteria, but not exactly. And I'll get into the criteria later on. These are sort of meet the criteria, but not fully, and they're like in between. And so they are classified as CRPS not otherwise specified. It's more for medical, legal, and research purposes. But for practical purposes, we'll stick to CRPS 1 and 2. So CRPS 1 is non-specific nerve damage. We don't know exactly which nerve is acting up. In reality, it's all nerves. All the nerves are acting up. It may be, even if a CRPS starts in one limb, if it starts in the left arm, the nerves are inflamed, but it also inflames other nerves at other places, including neuroinflammation in the brain. CRPS type 2 is a whole different animal, and unfortunately, they gave it the number 2, but it's actually a number 1. See, what I'm trying to say is that the first CRPS that was first discovered back during the First World War was CRPS type 2, and I'll talk about that a little bit. They both kind of present in the same way, the same symptoms and signs, but the important part about this slide is that you really need to know the difference, because that's where the treatment and outcome becomes different. So it's extremely important that when you're diagnosed with CRPS, you really should be, your provider should definitely be figuring out whether this is CRPS type 2 or CRPS 1. 99% of the patients that I see with CRPS come in with a diagnosis of CRPS and no numbers assigned to them, which is usually considered to be CRPS 1. And then when I go through the history and physical, it turns out that it's CRPS type 2. Now, having CRPS type 2 changes the game. That's the point. So if it's CRPS type 1, it's a whole different treatment and outcome as compared to CRPS type 2. So this, I don't want you to go through this whole slide, but this is official diagnostic criteria that was proposed by the in Budapest in 2004. It's about 16 years old and really needs to be changed. But in any case, this is one of the few conditions where they actually have a checklist. You have to meet 1, 2, and 3. Actually, you have to meet 1, 2, 3, and 4 out of 10 symptoms in order to be classified as having CRPS. That's the important thing. So you don't really need to remember this. This is mostly for the providers, but there are very few pain conditions that actually have such clear-cut guidelines in terms of diagnosis. So there's temperature change, there's swelling in there, and then there's decreased range of motion, then there's pain to touch. It is a constant pain that never ever goes down, but may have spontaneous intermittent exacerbations of its own. So these are some of the things that the provider has to recognize. For example, temperature asymmetry. So one limb is colder than the other, or one limb is warmer than the other. You can't do that by just talking to the patient. They have to actually measure it with a device and figure out whether there really is a temperature difference or not. Swelling and sweating, these changes are, so as a patient, I would recommend that you take pictures of your limbs and take both, make sure that you have both limbs in the same picture to show the difference between the color difference or if there's any swelling. So for example, if somebody has CRPS of their right foot and you need to have a picture that has both the left foot and the right foot so that your physician can look at it and say, oh yeah, that is red and that is different, it looks different, there is swelling there. Because when you show up at the doctor's office, you may not have a color change that day, because color change and the sweating and the swelling and all come and go, and that has become a issue with a lot of patients being misdiagnosed or being told that, oh, you're just making it up because I don't see a color difference today. And that's the reason for taking all these pictures. So in any case, this is the Budapest criteria, and this is the criteria that has been accepted and followed by everywhere. And you have to meet a certain number of them. In general, it's about 4 of them out of 10. And the other thing is that there should be no other diagnosis that can explain the signs and symptoms. I know they included the statement when they had the meeting in Budapest, but that statement does not hold true at this time. But in any case, uh, it's a pain condition that's, the injury had healed years ago and you continue to still have pain. And so this is where the statement comes in, that there's no other diagnosis that can explain the signs and symptoms. So testing for CRPS, there is no test. Let's be clear about that. X-rays, MRIs, bone density scans, 3-phase bone scans, blood tests, skin biopsies, nothing. None of those are tests that help in diagnosing CRPS. What helps in diagnosing CRPS is the Budapest criteria. And this is a question of just taking a history and examining the patient. So going through an EMG, I personally think that putting a patient with CRPS through an EMG should be unethical. But that's how it is, and that's how people do it. The only reason your physician may ask for a test is to maybe use to rule out anything else that he or she might be suspecting. So they might have an MRI, an X-ray, or something to rule out if there's anything else in there. But in reality, there's no test. So I'm going to stress on CRPS type 2 because in my personal opinion, CRPS type 2 is very commonly missed. I don't think I've ever seen more than 3 cases that actually walked into my office and said that they have been diagnosed with CRPS type 2. They're always diagnosed with CRPS with no number next to it. And like I explained to you before, it changes the game. So in CRPS type 2, the symptoms are pretty much the same. There's color difference, there's swelling, there's pain to touch, all of those are still there. But in this case, there's a specific nerve that's damaged, and that nerve can be identified. And that cannot be done in CRPS type 1. So a very specific nerve, let's say there's a nerve in my arm called the radial nerve. And if my radial nerve is damaged, then and I get CRPS, then that becomes CRPS type 2. So just to give you some examples, what I mean by specific damage, I'm going to pick up one example from the arms and one example from the legs, and then in general. So in the arm, there is a condition called thoracic outlet syndrome, or there can be a condition called ulnar nerve entrapment that can produce symptoms of CRPS, and that is CRPS type 2. In the legs, patients, and this is very common peroneal neuralgia, where there's a nerve called peroneal nerve that is inflamed, and that is CRPS type 2. And that again is really important to identify that. So if somebody comes in with leg pain, CRPS of the leg, one of the top things to do is to figure out whether this is type 2 or not, and is to look at the peroneal nerve. Ehlers-Danlos syndromes is a condition where patients have joint hypermobility. Their joints are loose and lax. So when they move their joints, it stretches the nerves. And when they stretch their nerves, they obviously get inflamed, and then they have developed symptoms of CRPS. So that's the other thing. So if somebody develops CRPS for apparently no reason, or from a minor injury, just to make sure that there's no underlying joint hypermobility is really important. So as part of my CRPS type 2 promise, I'm going to talk to you about thoracic outlet syndrome. So in this picture, you can see a classical picture of pain going down, pain in the upper back, going down the arm into the fingers. And it looks like, either this pain is coming from the neck, or if this pain is, or it's CRPS pain. And of course, if it meets the criteria for CRPS, then would you call this CRPS 1 or 2? And as you can see, the pain distribution in this case is very specific. It's in the thumb and the index finger, or it can be in type 2, it can also spread to the other fingers, but not as much. Um, so why does this happen? What happens in thoracic outlet syndrome? In this, you can see the collarbone, and then you see the first rib. I'm not sure if you can see my cursor. Let me see if I can get a. All right, so this is the collarbone. This is the first rib. And so between the collarbone and the first rib, there's a gap. And in this gap, there are nerves that kind of sneak through the muscles. These are called the scalene muscles. They sneak through, and under the collarbone, above the first rib, behind this muscle called the pec minor, they go down to your arm. Now, for if any reason this muscle was to squeeze itself, or this muscle was to squeeze, or this gap would shorten down, the collarbone would shorten down on the first rib, it would compress the nerve, and that nerve that goes down the arm would produce symptoms of CRPS. So it's really important to figure that out. And I'll show you later on. Obviously, if the patient has CRPS type 2, the first thing is to find out if it's CRPS type 2. And if it is CRPS type 2, then find out which nerve is the problem and why is the nerve being affected. And then, so managing the thoracic outlet syndrome would help cure this problem. And that's why it's important to look at CRPS 1 versus 2. Just since I'm on thoracic outlet syndrome, these are some of the treatments: physical therapy, Botox, kinesiotaping, and if all else fails, there is surgical correction. So you can see this is not your standard CRPS treatment. This is way beyond that. It's a whole different game. So recognizing that a patient has thoracic outlet syndrome and has CRPS from it, that would make these treatments more valid. So this is another example of CRPS in the leg. And this is a nerve. This is a nerve you can see over here. This is the knee, the lower half of the knee. And you can see this nerve over here as it travels around, it winds around this bone. It's on the outside of your knee, below the knee joint, it's outside of the knee. And sometimes, for a million reasons, this nerve can get inflamed. It could be from an ankle dislocation, from a knee injury, or from a knee surgery. This nerve gets damaged, and these patients develop symptoms of CRPS type 2 in their leg. And again, there's difference. The treatment for this is a whole different scenario, where these patients need to be treated accordingly for an inflamed peroneal nerve. So that's the significance of CRPS type 2. And there's nothing in the literature which one is more, CRPS type 2 or CRPS type 1. I didn't find anything in the literature, but from just having seen patients with CRPS for the last 20 years, I feel that a significant number of patients have CRPS 2 and are being missed. One of the key things I just remembered I want to tell you was that, you know how we worry about spread in CRPS? In CRPS type 2, the pain does not spread. Because it is limited to only one nerve, it does not spread. Whereas in CRPS 1, because it is not limited to one nerve, it could be several nerves affected, it can spread. So let's talk about CRPS type 1. And this is, one of the things you have to understand is that the treatment of pain lies in understanding what's broken. Once you fix what's broken, then it takes care of the pain. So think of you driving a car and you hear a noise. The treatment for that noise is not to crank up the radio and put on headphones. you won't hear the noise, but you're not treating the problem. And sure enough, after a mile, the wheel is going to fall off. The treatment in this case would be to stop, look for, analyze, and figure out what's causing this noise and fixing that, and then moving on. So treatment of pain always lies in finding out the cause of the pain, what's broken over here. So, there's been talk about, we don't know why people have CRPS1, and there's been a lot of conversation about that. But as the years have gone by, we have started to look at autoimmune conditions more and more, because we've seen that autoimmune conditions are much more prevalent. They weren't as prevalent before, but in the last decade or so, they've become a lot more prevalent. And the question has always come up, is CRPS type 1 an autoimmune condition? So that means you're not born with an autoimmune condition. So let me explain what an autoimmune condition is. An autoimmune condition is your own immune system, which is supposed to protect you, starts destroying your own tissue. So your own body becomes your enemy. So your own soldiers, the antibodies that you have that are supposed to fight off any infection, start to destroy your own tissue. And so that becomes an autoimmune condition. Excuse me. Now, when someone has an autoimmune condition, to give you an example, rheumatoid arthritis, lupus, these are autoimmune conditions. They cause inflammation of the tissue. And so it's now called autoinflammation, because this is inflammation that's being automatically created in your body by your autoimmune condition. So what happens is when someone develops an autoimmune condition, it releases certain chemicals, and some of these chemicals are called one of them is called CGRP, and you've got the whole term there, calcitonin-related gene peptide. The reason I'm mentioning this is because I'll refer to this later on. There's some good news on this. Then there's substance P, which is the same thing as hot chili pepper. And so imagine having hot chili pepper thrown into circulating in your body. And then there are cytokines. I call cytokines more like text messages. They send messages of pain to each other. So anyway, these are some of the chemicals that are produced in the body. There is a whole slew of them. I just picked up a few of them. So these chemical agents that cause inflammation may be released. They are usually released by mast cells. And that is the main subject of my talk today, is these mast cells. So these mast cells are found everywhere in the body. They're normally found, and they're part of your immune system. And think of them as the National Guard. They're under normal circumstances, they remain inactive. And then when there's an issue, when there's a problem, these mast cells get activated. And when they become activated, they release all these nasty chemicals like histamine, cytokines, CGRP, and all these, which cause redness, swelling, and pain, which is exactly what we see in CRPS. So that is the reason why physicians are now starting to think that is CRPS1 an autoimmune condition? Or is it related to a condition called mast cell activation syndrome? So we're not quite sure why some people develop a severe autoimmune response to an injury. We don't know that. A person, not in relation to CRPS, but a person may have a simple viral infection, and that would result in their immune system going haywire, and they have an severe autoimmune response that can last maybe their whole lives or for many, many years. And that's one of the things that we are seeing with the present pandemic, with the COVID-19, is that patients are getting better from the COVID. The COVID is gone. They don't have the coronavirus anymore, but they still continue to have autoimmune responses and autoimmune dysfunction. Mast cell activation syndrome is a relatively new condition. We've kind of come to realize this about a decade ago. I mean, it's probably been there forever. It's just that we've started to recognize this about a decade ago. And it explains the severe inflammation of the nerves that we see in CRPS1. So is it possible that CRPS1 is a form of mast cell activation syndrome? And that's just my thought. And we've not identified it. For example, 10 years ago, no one knew what mast cell activation syndrome is. Now, people are starting to talk a lot more about it. There's a lot of more conversations about mast cell activation syndrome as being a very painful condition. Is it possible that down the line we may discover that there's a specific subset of mast cell activation syndrome that causes nerve inflammation resulting in CRPS1? So what happens in mast cell activation is that these mast cells start to misbehave, and we don't really know why they misbehave. Obviously, it's the autoimmune dysfunction that causes them to misbehave, but we have no idea why they misbehave, and that's the mystery. So once they misbehave, which means that they get activated, they imagine the National Guard going rogue, and so they start to shoot their own citizens. So they release chemicals that cause inflammation of the nerves. And this is especially explains CRPS1, not as much CRPS type 2. There might be some component of that in CRPS type 2, but it generally applies a lot more to CRPS type 1. There's obviously this topic on mast cells and the autoimmune thing is a whole different talk. So I've just kind of cut it down to some bare facts. So the question is now, how do you treat these misbehaving mast cells? It's generally divided into three parts. The first part is, these mast cells release histamine. So why not take something that will block the effect of histamine? Famotidine, commonly marketed as Pepcid, is a good histamine blocker, which is actually histamine type 2 blocker. Along that, you can take either Benadryl or my favorite is clemastine. These are generally just cold medicines, which are histamine 1 blockers. When we talk about antihistamines, when you get a cold, that's what we're talking about. The reason I like clemastine is because it also works on pain at the same time. So for me, that's the drug of choice. But any other can be fine: Benadryl, Claritin, Zyrtec, any of those. The second part of this treatment is to take mast cell stabilizers. And there are 3 of them in this group. Quercetin, you can buy that online. It's over the counter. I call it pineapple in a pill because it's made from pineapples. But quercetin is a very good mast cell stabilizer. Cromolyn and ketotifen are very good mast cell stabilizers also. They are prescription ones. Cromolyn is more limited to the source of where the mast cells are activated. So for example, if it is in the GI tract or if it's in the lungs, then it's cromolyn is used there, and ketotifen is more systemic. And then the final one is using immunomodulating agents like IVIG or Xolair and all those. There's also this one little section I didn't put in there, was to look for any triggers that might be causing. So look for triggers that might trigger your pain. So in some people, it could be temperature change. So you go from a hot room to a cold room, your hot shower to a cold bathroom, or when you go out in the sun, the rays of the sun can trigger mast cells. Stress can trigger mast cells. So that's why when people say that their CRPS pain has become worse because of stress, that's the reason, because it does trigger mast cells. So this is the part where I wanted to talk to you about generally about CRPS that I think may not be covered by other speakers, and I wanted to touch quickly about that. One of the things I also want to talk to you a little bit about there's no such thing as CRPS they don't call CRPS of the abdomen as CRPS. They're referred to as neuropathic pain in the abdomen, means the nerves in the abdomen or the GI tract are painful. And one of the commonly missed conditions of neuropathic pain in the abdomen is a condition called MALS, or median arcuate ligament syndrome. What do these patients present with? In median arcuate ligament syndrome, or MALS, they present with belly pain. It's very severe, excruciating belly pain, like CRPS pain. It increases as soon as you eat. Right away, it increases. It is associated with nausea. Patients often get tired after they get to take a meal. It gets worse if you're active and exercising. Certain postures make it worse, like for example, standing upright or sitting upright makes it worse, and lying on your side makes it feel better, or lying on your stomach makes it feel better. So what happens in males? In this condition, what happens is there's an artery called the celiac artery, and this artery supplies blood to the GI tract, and this artery is coated with nerves, which also go to the GI tract. And these nerves are called the celiac ganglion or the celiac plexus. So along with the artery, this mesh of nerves travels, that's called the celiac ganglion. They go out and they, there's blood flow to the intestines, and then there's a nerve supply to the intestines. But they travel under this ligament. It's like an arch. It travels under the arch. What happens is, in these patients, for different reasons, the arch becomes tight. And when it becomes tight, it squeezes that artery at the nerve. When it squeezes that nerve, they develop this pain, this neuropathic pain in their abdomen. Obviously, you need to rule out anything else that might be going on in the abdomen. Generally diagnosed by doing an MRI or a CT scan or ultrasonography. They use an IV dye, they inject the dye, and then they look at the blood flow through that celiac artery, and from there they can judge it. Unfortunately, the treatment for this is surgical. That's the bad news, but the good news is that the surgical treatment does produce amazing results. This is the picture I wanted to show you, and on the left, you can see this is the normal picture on the left, and you can see this is the aorta, which is a big pipeline that goes down your abdomen. And this little thing that comes out from it called the celiac axis, which is just a celiac artery. And the arch is over here. This is the arch, the median arcuate ligament. What happens is that in some cases, either the arch descends or the artery moves up. Whatever happens, it squeezes this artery. And along with this artery are the nerves that go to the intestine, and they get compressed also. And that's why these patients present with neuropathic pain. I know there is lots of talk about management of CRPS, and there's some really amazing talks that I've seen. They're all valid. There's absolutely, my theory on management of CRPS is, look, there is no treatment that has been approved. So whatever works for you, try it, as long as it does no harm. That's the philosophy. So as long as it does no harm, try it. So if somebody says, take iron tablets and your CRPS will get better, give it a try. If it doesn't get better, then move on. So obviously, you've got to treat the cause. We talked about CRPS type 2. This is about CRPS 1. In CRPS type 2, you treat the structure that's causing the nerve compression or stretch or inflammation of the nerve. If it's an autoimmune dysfunction, then you treat the autoimmune dysfunction. A specialist that does handle autoimmune dysfunction is usually an immunologist. And so it's worth looking for an immunologist. They are far and few, but if you can find one, that'll be great. And then, of course, treating mast cell activation syndrome if you have the symptoms. Some of the treatments that are used that have been in the literature for quite some time is low-dose ketamine infusions, magnesium infusions. Even magnesium topical does quite well, actually. So you can actually get magnesium lotions and magnesium oils or Epsom salt bath. All of these can work well. Alpha lipoic acid is a radical scavenger, so you can use that. And then you have N-acetylcysteine. You know how patients with CRPS have one cold leg and a warm leg? This is the drug that helps the cold sensation. So it literally warms up the leg. These are available over the counter. Absolutely check vitamin D and calcium levels. In fact, you'll see this in the news a lot, vitamin D levels, because they've been asking people to stabilize their vitamin D levels to help prevent autoimmune dysfunction from the coronavirus. Some of the treatments that physicians have been using, these are very old treatments like carbamazepine, phenytoin, lamotrigine. I have not been impressed with their results. But if your physician wants to try it, absolutely go for it. It can help. A lot depends on the physician's experience also. And it can. There's no harm in trying it. Like I said, as long as it does no harm, it's worth trying it. But this is the treatment, as I told you about earlier on, do no harm. Spinal cord stimulators have very mixed results. They're not great. At best, they might work for a very short while, and the complication rate with spinal cord stimulators is extremely high. I'm not sure whether it's because of spinal cord stimulator or is it because of the experience of the people implanting it. We don't know that yet, because most physicians go for a weekend course and learn how to put this in. Um, But again, you remember how I gave you the analogy of if you have a a noise coming from your vehicle, you don't crank up the volume of your music, the radio, or put on headphones to block the sound. You go and look for the cause. The spinal cord stimulator is cranking up the volume. That's how it's supposed to work. Actually, we don't even know how it works, but it does not treat the issue. It does not treat the problem. The same thing with peripheral nerve stimulators. Capsaicin cream, if you have a death wish, then use capsaicin cream because that's really just hot chili pepper. Neridronate has been a huge flop. I haven't seen one success. The one paper that came out from Italy was pretty much not true. So please don't waste time and money on that. This is one of the more, one of the drugs that I have found very useful is called low-dose naltrexone. Without going into too much into the science of it, LDN generally increases endorphin levels, and endorphins are the most powerful painkillers that you can ever get. It also produces growth. It also stimulates growth, tissue growth. So there's also repair in there. So it helps with neuropathic pain. That's the key one here. It decreases fatigue. We're now starting to get feedback from physicians saying that it has been helping with symptoms of mast cell activation syndrome. So it's a win-win everywhere. It's worth a try. It's not an expensive drug, and there's no harm in trying it. Generally, you start at 1 to 2 milligrams in the morning for approximately 2 weeks. That's the way I do it. Different physicians have different protocols, and they're all fine. The dose to look for is about 4.5 milligrams. And that's usually my stop, where I stop at 4.5 milligrams. And most physicians do that, 4.5 milligrams. There have been physicians who have told me that they have gone up to 6 milligrams and even 12 milligrams. And I see no harm in doing it, provided it's taken only once a day. That is the absolute key thing over here. It should be only taken once a day, and not more than once a day. You can take it in the morning or at night, depending on the side effects. In some people, it causes insomnia. In some people, it makes them sleepy. So depending on what you get, you can take it in the morning or night. It doesn't really make a difference. The side effects are very temporary. They're headaches, insomnia, and colorful dreams. These usually go away after some time. But again, just wanted to stress that it should be taken only once a day. It takes a few weeks. It's not a painkiller, and so it takes a few weeks to start seeing a response. Most physicians who prescribe it like to wait for 6 months. So they want to see patients on it for at least 6 months to see if they can get any benefit from it. Very rarely, some patients may have, from the 1 milligram itself or the 4.5 milligrams, they may see some side effects, like it just makes them throw up or something like that. Don't give up. Try going to even a lower dose. Go to 1 milligram or even 0.5 milligrams. Not everyone fits into the same box. Some people may need a higher dose. Some people may need 4.5 milligrams, and some people are just fine with 1 milligram. So it doesn't really, there's no fixed dose on this. It has to be ordered from a compounding pharmacy. And most compounding pharmacies are very good at it, and they're very careful about not putting any other chemicals in it that can cause reactions like preservatives or binding agents. And like I said, it's reasonable if you don't see a response at 4.5 milligrams, then going up to 6 milligrams or 12 milligrams is not a bad idea. The other one is intravenous immunoglobulins. These are usually done by immunologists and neurologists who specialize in immunotherapy. So essentially what happens is, remember I told you how your own antibodies turn against you. And so this is essentially giving you an infusion of good, healthy antibodies. So you're getting rid of those rogue soldiers and you're now getting good soldiers in there to help protect you. And so remember we talked about how one of the theories about CRPS1 is that it could be an autoimmune condition. This would be a more definitive treatment for that. So this would be the thing, treating what's broken. I promised you I'd talk to you about CGRP or calcitonin gene-related peptide. This is a tiny protein molecule that's produced, and they found that nerves that hurt produce this chemical. And so whenever a nerve gets inflamed, they realize that this chemical is always there. Among other chemicals, this is always there. And so the studies that were done mainly for migraines. So that's where the research was. They looked at migraines only, and they found that in migraine is a lot akin to CRPS. It's not the same level of pain, but it's in some ways it can do that. It causes the same issue with central sensitization and all that. So the research was done only with migraines, where they looked at the nerves in the brain were producing this peptide called CGRP. So they started producing drugs that would act against the CGRP. So they produced CGRP antagonists, and right now there are 3 of them in the market. They are marketed as Aimovig, Ajovy, or Emgality. These are all injections, actually, very tiny injections done once a month. Ajovy is done once in 4 months, and the other 2 are done once a month. So far, they've been only approved for migraines, but I'm very optimistic that this will eventually get approved for neuropathic pain. And if you happen to have migraines along with CRPS, it's certainly worth talking to your doctor about trying these and seeing if you could kill 2 birds with 1 stone. There's always been a discussion about ketamine and the misconceptions behind it. It's a very powerful analgesic at low doses, not at high doses. At high doses, it can cause a lot of cognitive effects. And so, unfortunately, when taken as a pill, it's not really absorbed well. And so you have to take higher doses, and it's not very, the effect is very unpredictable. So most people try it as an IV or sublingual under the tongue, as known as a troche, or as nasal spray. And the absorption is relatively better in these cases. But you've got to remember that ketamine infusions have to be done in conjunction with other therapies. So if you respond well to the infusion, then it's really important that you starting exercising on your own, getting to move your limb a little more and more every day, and getting this under control, getting your vitamin D under control, calcium under control. All of these things have to come together. Ketamine is not fixing what's broken. Ketamine is covering it. It's a Band-Aid. It's not fixing what's broken. It's giving you a reprieve so that you can focus on your other therapies to get it better. The good news is that the FDA has approved ketamine nasal spray for treatment of depression. So it's kind of becoming a little mainstream. So people are now a little more accepting of it. In the past, it was a no-no, but now there are a lot more centers that are doing it. Just to be sure, there are psychiatrists there are physicians who have been using ketamine IV for treatment of depression. The dose and the protocol is different for CRPS from treatment-resistant depression. And I'll give you the protocol for the CRPS, ketamine for CRPS. So essentially what happens is in small doses, in low doses, it blocks the NMDA receptor without causing too many side effects. And NMDA receptors are these receptors that get activated in CRPS. And so it helps decrease central sensitization, which is one of the reasons for CRPS. And rough estimates, we don't have any clear data on this, but rough estimates about 85% of patients respond to it. Now, the protocol, the outpatient protocol usually followed by most centers is that they do it over 10 days. and that's called the loading dose. They start at a really, really low dose on day one, and then they increase it progressively every day, depending on how your response was on the previous day. The infusion is done very slowly, and it's given over 4 to 5 hours. It requires full standard monitoring. So there should be cardiac monitoring, there should be pulse oximeter, there should be a non-invasive blood pressure monitoring going on constantly. There should be qualified personnel available at all times in the room. That means there must be a qualified nurse at all times and a physician available at all times close by. Um, so this was the loading dose. Once the 10 days are over, then you come to the boosters. And so what happens is, this is a really important part of the treatment protocol. And again, as the initial effect of ketamine starts to wear off, the pain starts to return, the glial cells get activated again. So it's important to do the boosters. Most centers, what they do is, they'll either do a 1-day or a 2-day booster every 4 to 8 weeks, depending on how severe the CRPS is and the response to it. Obviously, the protocol has to be customized to each patient. And with that, I end my talk. I hope it was helpful. My grateful thanks to Roxanne for starting the CRPS Forum and developing it to where it is right now. Thank you very much.